Hello, we are Group 14. We are Alexander Lin, Elizabeth Yiman, Kun-hee Cho, and Youngwook Jung. Our study is cost effectiveness of hydromorphone for severe opioid use disorder, findings from the SALOME randomized clinical trial in 2018. The primary author of this study is Nick Bansback, and this study is a collaboration between St. Paul's Hospital and University of British Columbia, both in Vancouver, Canada. With regards to the SALOME trial, it is a 6-month phase 3 double-blind non-inferiority trial. It included 202 patients with severe opioid use disorder in Vancouver, Canada. They were randomly assigned to 2 groups, one group being hydromorphone and the other group being diacetylmorphine, both of those being injectables. They also indirectly compared these 2 medications to oral methadone treatment using previous trial data from the NAOMI trial. So is the title appropriate? With regards to the title, it does specify the study type and disease. However, it does not include comparators, country, or setting. Overall, the title does not seem inherently biased. Is the objective of the study clear? So there is a clear objective stated within the study. The objective states, the current study has aimed to compare the cost effectiveness of hydromorphone directly with acetylmorphine and indirectly with methadone maintenance treatment. Were the appropriate alternatives or comparators considered? Well, the authors do discuss how diacetylmorphine is a potential cost-effective treatment option in opioid use disorder, and they do compare it with hydromorphone and indirectly methadone, but they are comparing injectable options to oral options, and they leave out other conventional treatments that are commonly used, such as buprenorphine, which is found in Suboxone, as well as naltrexone tablets. And the authors do go into this, saying the study is conducted in Canada, and buprenorphine is not readily available in that area.
Was a comprehensive description of the competing alternatives given? Based on the information given, another researcher could not duplicate results from numerous results because numerous variables are missing in the study. First, dose of studied drugs. Second, duration of treatment. Third, any additional pharmacist training involved. 4, personnel and administrative costs. 5, summary of services provided. However, authors did describe how they identified patients and type of follow-up and resources required. Is the perspective of the study addressed? This study was conducted from a societal perspective for all measurements, including direct medical costs, direct non-medical costs, and indirect costs, incremental costs, CALI, cost-effectiveness ratio. However, intangible costs were not measured. However, sensitivity analysis utilized different perspectives, assumptions, and evidences. Is the type of study stated? In the study, the type of study was clearly stated as cost-effectiveness study that used CALI and cost-effectiveness ratios as primary outcome of measurement.
Were all the important and relevant costs included? The analysis included cost of drug treatment, cost of resource utilization, including the cost for HIV treatment, inpatient care and outpatient care, cost of crime that included cost of involvement in property and violent crime as well as criminal charges. The costs related to criminal activity included costs borne by the criminal justice system and out-of-pocket costs resulting from a victimization. From the comparison of cost for hydromorphone and diacetylmorphine, incremental adjusted costs and QALYs. Intangible costs such as pain and suffering were not measured. Were the important and relevant outcomes measured? Authors measured relevant clinical outcomes including utilization of drugs, visits to health professionals, hospitalization, criminal activity, as well as mortality and quality of life. However, authors did not discuss adherence to treatment regimen, and the outcomes such as pain and suffering were not measured as well. Were adjusting and discounting appropriate in this study? Health-related quality of life is incorporated in terms of utility values on a scale of 0, which is equivalent to death, to 1, which is full health, combined with life years to generate QALYs, and discounted at 5% per year. All costs were calculated by multiplying resource used by respective unit costs adjusted to 2015 dollars, and discounted at 5% per year to calculate present value. The 5% discount rate is cited from the source listed below. Are assumptions stated and reasonable? Most assumptions or estimates were stated and reasonable. However, there were some assumptions that were questionable. The first one being drug costs, which were estimated based on the dosages reported in the study. The authors did not disclose which manufacturers were used in drug cost estimates. The second was the cost of drug treatment for HIV infection, which were based on the estimated proportion of infected patients receiving treatment. Lastly, criminal involvement was self-reported, which may influence cost estimates related to criminal activity.
Were sensitivity analysis conducted for important estimates or assumptions? A sensitivity analysis was used when determining the drug cost, the active pharmaceutical ingredient price, and associated cost of production. To account for the linear mixed effects regression model that controls for age, sex, and HIV status and cost over time. And lastly, cost estimates related to criminal activity. Were limitations addressed? Limitations were addressed in the discussion section. Self-reported criminal involvements limited to property and violent crimes and did not include the possession or dealing of drugs. Disorderly conduct, sex work, major driving violation. Relied heavily on extrapolations beyond the trial data on transitions between treatment states. Lack of accessibility to other potential treatment options such as buprenorphine. This could have potential influenced generalizability. Time analysis included only one state of relapse. Unadjusted involvement in violent criminal activity was higher in HDM versus DAM. Comparison of HDM and methadone were indirect, more susceptible to bias. Were extrapolations beyond the population studied proper? Study results were based heavily on extrapolated data. Outcomes of SALOME trial were extrapolated to estimate long-term efficacy. Cost and quality were extrapolated to a 50-year time horizon and compared to oral methadone.
Was an unbiased summary of the results presented? Well, according to the authors, in patients with severe opioid use disorder enrolled in the SALOME trial, injectable hydromorphone provided similar outcomes to injectable diacetylmorphine. Modeling outcomes during a patient's lifetime suggests that injectable hydromorphone might provide greater benefit than methadone alone and may be cost-saving, with drug costs being offset by costs saved from reduced involvement in criminal activity. There is bias in the summary of the results presented by the authors. In the comparison between hydromorphone and methadone, it was achieved through an indirect comparison, which made the results more susceptible to bias. The study also included extrapolated data, which tends to make the results less reliable. As well, key comparators were also left out of the study, namely buprenorphine, and the authors compared injectable options to the oral option, which is methadone. These factors led us to believe the study summary was biased. So in conclusion, overall, the article had numerous flaws in its method of analysis. The study concludes that lifetime modeling suggests hydromorphone is cost-effective to methadone despite greater direct cost, because drug costs are being offset by costs saved from reduced criminal cost. However, measured criminal costs may not adequately include all related costs and may undermine the actual economic effect of criminal involvement among studied patients. Moreover, criminal rates were self-reported. The method of allocating patients into groups was not described, introducing allocation bias. Many important baseline measurements were not reported, such as income, education, comorbidities, and pain level. This does not paint a clear picture on the patient population, and this negatively influences the external validity of the study. So, in conclusion, more cost-effectiveness analysis studies of higher quality need to be done to assess the cost-effectiveness of these agents and to determine their place in therapy. Thank you for listening to our presentation.